Dear audience, I'm Csaba Varga, PhD student in the orthopedic department of the Semmelweis University, and my PhD program is about the indications in foot surgery, especially in the surgery of flatfoot and ankle replacement. I would like to achieve that the international professional results in foot surgery are widely used in a clinical practice in Hungary as well, and with my scientific work, I would like to contribute to the development of professional guidelines. The first part of our work is to assess the prognostic role of BMI in ankle replacement procedure, and the other part of our work is the comparison of the operative techniques in the treatment of adult flat foot deformity in each stages. Our first project is investigating the safety and efficacy of total ankle ultraplasty in relation with body mass index. Something about the background. The amount of ankle arthroplasty procedure has increased quickly in the last 20 years, as the figure shows. And as the amount of ankle arthroplasty raises, the complication rate is increasing as well. The most important complications can be seen on the slide, divided them into local and systemic groups. The ankle arthroplasty works with a higher complication rate as the hip and knee arthroplasty. Therefore, is it crucially important to know the risk factors of the complications. There are proved prognostic factors which can lead to these complications. For example, diabetes, smoking, arteriosclerosis. But what about the role of BMI? In a clinical practice, BMI is a crucial criteria in the patient selection because the negative effect of BMI to the outcome of hip and knee arthroplasty is proved. But in case of ankle arthroplasty, the prognostic role of BMI is still unclear. As the example shows, two scientific articles has appeared in the same year in this topic. One of them shows the negative effect of high BMI, and the other says it has no effect to the outcomes of ankle arthroplasty. In general, BMI and high body weight is source of many problems in orthopedic surgery. For example, arthritis, enthesopathies, overloading joints, muscles, and tendons. That's why our aim was to clarify the role of BMI as a risk factor for complications and for revisions after primary ankle arthroplasty. And our clinical question was the same: does BMI increase the rate of complications and revisions after ankle arthroplasty or not? And our hypothesis was complications and revision procedures appears in a higher proportion in case of obese patients. In our meta-analysis, we collected the articles from 3 scientific databases, and we have done the systematic selection, and we got 29 articles to make the analysis. This is our first forest plot about the revision rate, divided the patients into obese and non-obese groups. The random effects model shows more than 1.5 times higher rate of complications in case of obese patients with a low heterogeneity between the populations. It means that an obese patient has more than 1.5 times better chance to undergo a revision procedure as a non-obese patient. Some of the articles provided subgroups with narrower BMI categories. You can see them below. There seems to appear the difference in revision above 30 of BMI. That's why the breakdown 30 of BMI seems to be appropriate. We performed the analysis without, for revision without polyethylene exchange. And this sheet is about the revision rate affected the metal components of the implant. The chance to revision seems to be even higher as previously. This sheet is about the complications. because of the large heterogeneity between the populations, we could not prove the difference between the obese and non-obese patients. And some of the articles seems to show the positive effect of BMI to the complication rate, but we think it's because the different types of complications and the low power of the analysis. But we investigate them in general. We have got the same results in case of local complication rate, and we have not enough articles to achieve the appropriate power of the analysis. As a conclusion, we can say the revision rate is higher in obese patients after ankle arthroplasty, and the implication for practice will be we can predict and avoid complications, and the complications can influence the financial costs. So based on this, it's considerable to change the treatment protocol plan in case of obese patients. This is the state of our article. We will send it to the journal this month. And the other part of our work is the comparison of the operative techniques in the treatment of adult flatfoot. The adult acquired flatfoot deformity and the prevalence of adult acquired flatfoot deformity is around 15% between the adult patients, according to the latest studies, and 7 to 15% of EEFD patients needs to be treated because of the symptoms. The guideline provides a multiple choice of operations. As the figure shows, this is the flow chart of the operative treatment of adult flatfoot according to the guideline. It can be seen that one intervention is involved in several stages, and there are many methods to choose from within a single stage. There are little evidence which risk factors influences the success of operations and which procedures leads to better outcomes. So the guideline only provide options per stages, but the type of the surgery is currently selected based on the individual decision and the experience of the surgeon. That's why our aim was to compare the effectiveness of the different surgical techniques in the treatment of adult flatfoot, and our clinical question is simple: which is the best, which provide a better result? And our hypothesis was that there is difference between the different surgical treatment techniques. The clinical implication for practice will be to avoid the unnecessary procedures and reoperations, and to choose the appropriate and the best surgical technique in each stages. In our meta-analysis, we collected the articles from 3 scientific databases and made the systematic selection, and we have found 54 articles to make the comparison, and this is the state of our second part of our work now. Again, an overview about the 2 projects, and I would like to close so our orthopedic profession needs simple rules, I think. Therefore, I want to close my presentation with this quote from an American computer scientist: "Simplicity is the shortest way to the solution." Thank you for your attention.
Thank you for the presentation. And I would like to know if you considered evaluating the body composition instead of the BMI for these outcomes. Because we know that, for example, the muscle tissue is a protective factor for many outcomes in clinical practice, in hospitalization, for example, and the visceral fat, subcutaneous fat can be a harmful effect, can have a harmful effect. So I would like to know if you consider, for example, evaluating tomography or MRI or bioimpedance or ultrasonography instead of BMI to see these outcomes in the replacement.
Yeah, to evaluate the success rate of this operation method, these are the scores, and these are very well to evaluate the success rate. but we are investigating BMI as a risk factor. So yes, we have other way to assess the success rate, but it's not necessary. So the main question for us is to make that operation or not. So I mentioned it previously. So it doesn't matter for us that which is the relationship between the illnesses and ankle arthroplasty. So the real question is to make that individual operation or not to make that individual operation. And to make this decision, the most important thing for us, the rate of complication. And still now, it was not proved that BMI is a risk factor. We could estimate it, but it was not proved. Okay.
Okay, thank you. And to know if you would consider other techniques instead of BMI to have a higher precision, and maybe later you would find protective factors and risk factors related to body composition in these surgeries.
It's very difficult to answer to it.
I'm sorry?
It's very difficult to answer to this question.
Okay.
Thank you.
Csaba, just one more question, if you are not so tired. You stated that the failure rate in obese patients is much higher comparing to not obese patients. And what is the take-home message, or what would you write in your article to find a borderline for the patients to be operated on with BMI or obesity, or just we stated that and we go further?
Yes, as the clinical implications. So to make this decision that I mentioned is the task for the individual surgeon. We would like to facilitate this decision with these results. So with a high BMI, you can make the operation for that individual person, but you have to know the risk as you make the decision to make it. So this is a quantitative amount of the risk. So whether you have to get the risk at the decision to make the operation, or the other chance to try to ask for the patient to decrease your weight under BMI of 30.
Thank you.
If I can ask that, probably I shouldn't ask, because as I look around, I have the highest BMI in the room, so maybe those should shut up. Anyway, but I think that's interesting and important, and actually you do that in your you just didn't reply that. Besides BMI, I mean, if somebody has diabetes, somebody has high blood pressure, somebody has this kind of metabolic syndrome, I mean, these are all adding. I mean, BMI is good because that's easy to measure. But there are a couple of other factors which actually synergistically actually increase the risk.
Yes, these are confounding risk factors, yes, it's true. But it's the main problem of us, how to investigate them. Some of the articles says that controlled BMI has no influence to the outcome of ankle arthroplasty, and the uncontrolled BMI has. And this is in relationship with body mass index, but it will be a statistical analysis method to assess the relationship between them. It's very difficult, yes.
Okay, thank you.